Welcome to the Ultimate Dental Podcast, the place where you can learn how to create a dental practice and a business life that you love. Listen in with Dr. David Moffet as he interviews successful entrepreneurs and successful business people and successful dentists as they share their business successes, their stories, and their breakthrough ideas. Sharing pearls of wisdom that you can take back to your practice and implement immediately so that you can have that great practice with more patients, higher profits, and less stress. This is the podcast where great dental practices meet with successful business processes. Thanks for tuning in to the Ultimate Dental Podcast, the podcast where thought leaders, industry experts, and thriving practice owners reveal their very best tips, tools, and strategies that will help you to grow your dental practice faster. Now, here's your host, Dr. David Moffet.
Hi, everybody, and welcome to today's episode of the Ultimate Dental Podcast. I'm your host, Dr. David Moffet. I'm in Burrawang in New South Wales, as you all know, 2 hours southwest of Sydney, and it gives me great pleasure to be talking to somebody in my own time zone again today, Dr. Anikó Ball from Melbourne. Anikó, welcome to the Ultimate Dental Podcast. How are you?
I'm really well. Thank you for the invitation.
Lovely to talk to you. You and I have known each other for a long time through social media and LinkedIn. We work in the dental space, in different parts of the dental space, and I'm a big fan of what you do. You work with posture for dentists, and I think that's really important because the longer that I have been a dentist, or I was a dentist, I practiced for 35 years and another 8 years on top of that still consulting with and coaching dentists, the more I find people saying dentistry is really taxing on the human body for dentists. And you're, I guess, an angel sent along to help dentists to be able to practice longer without pain. So tell us your story. Tell my listeners and my viewers your story of how you ended up in the physical space of dentistry after becoming a dentist.
Well, it's an interesting story. I was already in pain when I was a dental student. If your listeners are wondering about my accent, I was born in Hungary and came here as a teenager. I experienced even more pain once I began to practice in general practice. Then I limited my practice to periodontics, dental sleep medicine. I loved my dentistry. However, I had severe neck, back, shoulder pain, sciatica. There were times when I couldn't even get to my shoelaces. I felt like a 100-year-old woman. I went to every medical specialist, physical therapist I could think of for over 30 years, and they were very helpful. However, all they could do for me was treat my symptoms. No one actually asked me, well, Anikó, show me, what do you do? How do you do dentistry? Anyway, after being told that I was a hopeless case by several treating specialists and I was desperate for help, I came across the inner ergonomic principles of the Alexander technique, which I'd never heard of, and began looking into it. At first, I thought I'll just learn a little bit from workshops and books. And then in the end, I literally felt an inner calling, to my great surprise, that I should do the over 1,600 hours in-person training at the Melbourne Alexander School. Just as I was about to embark on further training in laser perio, that was my absolute passion at the time. But something in me said, Anikó, you need to do this. So I continued part-time dentistry, part-time training over 4 years. And then I realized that the way the Alexander technique had been taught for over 100 years, very successfully to the performing arts world, could not possibly be taught in that way, in kind of a bohemian fashion to the dental world. And then I spent an extra 1,000 hours on top of the 1,600 hours or more in training. I spent all that time translating what I learned into dental industry-specific application. And what I now teach is what I call the Dental Work Posture User Guide that we ought to have received during our dental training. It's about how on earth do you get your pair of hands and get your eyes to see into the patient's mouth without damaging your body. My plan was to continue practicing part-time and focus on optimum dental posture. And then sometime later, I realized that there are enough dentists saving teeth. I need to save the profession, and that's what I'm doing. So I stepped out of clinical dentistry.
I think that's a great story and a great purpose as well, because there's a lot of things missing in the dental undergraduate education, apart from marketing, sales, HR, all those sort of things. But posture is hardly even taught, in dentistry. It's like, just sit up straight or use a mirror, but that's it. But what you're telling is the story that a lot of dentists end up finding out, sadly, by doing things wrong, incorrectly, and ending up in pain. And then that could have been prevented if they had been educated correctly and disciplined in their posture. I love it because, as I was telling you before we hit the record button, I've practiced dentistry for 35 years. I've got osteoarthritis in some of my joints, and I've personally had I had a motor vehicle accident that upset my neck, but I just put that down to the facts of life. People say to me, why have you got osteoarthritis? I said, well, just normal childhood. Fell off push bikes, fell off roofs, fell out of trees, all those sorts of things. They say, why did you have a shoulder replaced? I say, is it from golf? I said, if it was from golf, then all professional golfers would have had a shoulder replaced, because I don't play that much golf. So there are things that we can do and that we should do. And so I love the way that you have gone back to the start of the profession and said that we need to educate more dentists before they get the injuries, before they get the damage, then try and educate them after that they're in pain, because you went through that experience yourself. So tell us about the Alexander technique, and what is it that makes it stand out as the best way for the dental profession to protect themselves?
Well, what is amazing about I call it the inner ergonomic principles of the Alexander technique, is that I learned, and this is what I teach, is that some joints are not designed for prolonged bending and twisting or repeated twisting and bending. Some muscles are not designed for prolonged contraction. And there's a way that your body was meant to be working. The body has a certain design. Who knew there's a design to the body? I really thought, like all dentists, that I could twist myself into a pretzel, literally, and bend any way I needed to in order to get my work done as a student, and then even more so on that time pressure in private practice. And no one actually told me that it's not okay to do that when you do certain things that your body wasn't designed to do. And the problem is when we hold those postures. If you're in movement, you can twist and bend and do all kinds of things because you keep coming back to neutral. But when we hold up arms using muscles that are not designed for prolonged contraction, or bend our spine doing things that those spinal joints were not designed for, then we get into trouble. And it was only through the Alexander technique training and then my translation into the industry-specific application that I fully understood why we are in so much pain. And in fact, what I do, David, whenever I give a talk or I run workshops, is I say, my most important message is take care of yourself. You are your most precious instrument. However, taking care as a clinician, as a dentist, means that you need to know what to do and not to do with your neck and back when you are looking into a patient's mouth, what to do and not to do with your shoulders, arms and hands, and legs and feet as you do your dentistry. And I always ask, and recently I was talking to a group of 350 clinicians, and I asked, please put your hand up if you have learned any of this. Not one hand ever goes up. To me, David, it's a little bit like when you get your license and you are able to drive on the road. Imagine if you were allowed to drive without knowing that you have to stop at red lights or not to drive on the wrong side of the road. There are road rules to driving. There are road rules to the body, except we don't get to learn it.
That's interesting. And you just raised an interesting point there, Anikó, because like with the foot control, which foot control should we be using? The one where we're pushing down on in an up-down manner, or the one where we're pushing the pedal, left or right? There's two. One must be worse than the other for us.
Absolutely. And that's something I always cover. So first of all, people need to know that the knee and ankle joints are hinge joints, although the ankle has a little bit of rotation. And therefore, the design of the leg is such that you should be stepping up and down on an up and down foot control. When dentists activate a side activation foot control, they are twisting their knee and ankle, and quite often it leads to knee pain. And so when I teach, because I spend quite a bit of time teaching what to do and not to do with the foot control, I teach that if someone has a side activation control, then after moving the front of the foot across, then to migrate the heel to be in line with the front of the foot so that there's no twisting of ankle and knee. There's more to it, but that's one. So I look at what I have done, David, is I call what I teach the how and the way you do what you do in ergonomics. Anything that's not the dentist, not the clinician, I call that outer ergonomics. The outer ergonomics has to be right. So the foot control is an outer ergonomic item. And quite often outer ergonomic items are not well designed. I've seen some foot controls that have a very high profile. It means that the foot has to be raised a long way. So there are many things. At times I say to a dentist, you got to get rid of that foot control. It's no good.
That's interesting. And we were talking before. That's very interesting, because that's just something that we just take for granted. Oh, it's either this or that, and they're both neutral in their effect on the body. Well, obviously that can't be. We were talking before about my osteoarthritis in my thumbs and how I became aware of it when I had one arm in a sling, because I'd had a shoulder replacement. So all of a sudden I'm doing an unusual keyboard action with my left hand while my right arm's in a sling. And the osteoarthritis, again, somebody said to me, people would say, well, how did you get it? But it was actually a dentist many years after I was been diagnosed. And he said to me, you know what it is? He said, it's wearing latex gloves. And I said, how do you mean? He said, well, latex gloves are made of rubber, so they're compressing your hand all the time. So every time you're reaching with your hand, you're pushing against a TheraBand for 8 hours a day, and you're pushing out against this rubber that's always pushing back into you. Now, for me, what really was the kicker was that because I practiced left-handed, I set my chair up left-handed and I switched everything over, except I didn't switch over the air and water buttons on the triplex. So the one that I was reaching for furthest was the one that I should have been reaching the least for. The air button was the one I had to reach for all the time, whereas for a right-hander, the air button's right there. But the water one's the one they use less, so they reach for it further. And so therefore I'm doing more work with those thumbs and wearing out those joints. And you will love this story. When I went, because I had pain in my left hand, and the hand surgeon said, well, let's get an x-ray of both hands. And, he's like a manicurist. He was very soft-handed. So he sent me for x-rays, and he said, you've got less joint space in your right hand than you have in your left hand. That's interesting. And he then, the pinch test for your strength, this really threw me. My dominant hand, my left hand, my pinch strength was half the strength of my right hand. And who goes around measuring that themselves? It's some measure. And so all this that we just take for granted as being okay because it wasn't really causing pain. My pain was on the stretch. That was the initial thing. I go, oh, there's some discomfort there on the stretch. So again, by the time I get the pain, I'm already damaged goods. I'm too far gone. And in fact, that's what caused me to realize that I'm a liability as a practicing dentist holding sharp instruments. I could be dropping them because of my thumbs are now useless, really, in holding things. But it's interesting that what I'm trying to share is that the mindset that we have that we'll be okay isn't a mindset any of us should live with from the start. We should always be looking at how can we conserve ourselves so that we don't end up as damaged goods, not how do we treat ourselves when we become damaged goods.
Very much so. And adding to that, David, you were very accurate when you said that by the time we feel the pain, we're damaged goods. Trauma is cumulative. I talk about cumulative trauma. When we do something that the body was not designed to do, so we need to know body biomechanical design, and that's one of the aspects of the dental work posture user guide that I teach, is that trauma is happening, micro trauma at a cellular level, and it goes on for as long as we do what we do that we're not supposed to be doing. And it accumulates. At first, we don't feel it. By the time we feel it, it's been accumulating for a long time.
Yeah, it gets worse when you think, and I think at my age, like I wake up in the middle of the night and I go, must go to the bathroom. But it's not my bladder that wakes me up. It's pain in my shoulder or pain in my neck or something else. That's what's woken me up. And I go, time to go to the bathroom. Then you go to the doctor and you say, I'm having to go to the bathroom multiple times. And so we start treating something that is not really of significance, because the significance is the damage that we have done that's caused the pain in our shoulders. Or similarly for people who have sleep problems and snoring, they get woken up by a partner. But all these things accumulate with time. Let's get back onto the physical therapy side of things again. How do you go about teaching people about posture and its potential for causing irreparable damage, which it is, in the dental profession? How do you get those people to have that thought front of mind, as opposed to, I'll deal with it when it happens?
Well, actually, the greatest challenge, and I'll just add to what you said, is that often dentists think that they can just treat the symptoms or get it treated, plus strengthening. For example, someone is having neck and shoulder pain, and then they go to the gym and work out really hard, doing exactly the same thing that they're doing with their muscles that shouldn't be overworked, and do it in the gym. It's never about not having strong enough muscles. It's using the wrong muscles in the wrong way. Or doing various things, getting massages, very helpful. However, when it's done in the context of no habit change, work postural habit change, nothing will change. So my greatest challenge is to convince dentists that they need to deal with the cause. In dentistry, we do cause-oriented treatment. Imagine putting someone who has an apical abscess on repeated antibiotic treatment. But in a way, that's what happens for most pain problems, occupational chronic pain. Most of the time, it's not even recognized as occupational chronic pain. So no one looks at, well, what is it that this dentist is doing causing the shoulder or the back various pains? So I educate dentists who actually talk to me or register into my programs about cumulative trauma and how to recognize harmful habitual work postures. And whatever we do at work, we also do it outside work. So I train dentists on how to do things different, how to work with the body design away from dentistry and in the clinic. Because the very big challenge in all of this, once they learn what to do and not to do, is that the old default habit, which is harmful, is actually written in as software in the brain. That's not so simple to change. You can press delete on a computer when you don't want that particular software. Pattern interruption, this is a particular neuromuscular firing pattern that happens as soon as you think of something. And one of the greatest examples I always use is, do you take your head down to look at your mobile phone? Well, your spine wasn't designed for that. And I say, well, you've got a wonderful hinge joint called the elbow. Bring the phone to you. Don't take your head down, because you're not even doing dentistry and you're doing damage to your spine. And then I say, unless you can learn to break that habit away from the clinic, there's no way you can then break habits in the clinic. So that's the combination. And once I explain all this, dentists don't have any doubt about the truth of it. The challenge is to break the habits.
Yeah, it's you can't they say you can't unsee some things and you can't unlearn some things once you've been shown. And this is really important. How do we raise awareness, though? Are you getting enough exposure for what you're doing with undergraduates? Are there some schools that are ignoring you and others that are promoting what you do to help those students?
A very good question, David, and I'm glad you asked. So I have been invited by several universities to talk. At times I'm only given an hour, other times I've had 2 hours and I can do demonstrations. I've also done a little bit of small group training, and the faculty always says to me, Anikó, this is so great. And I say to them, please give me more time so that I can train students in the student clinic. And I do what's called kinesthetic guidance, where I actually place my hands on their head, shoulder, and guide them into more optimal posture and movement patterns and teach them. And they say, oh, we're too busy. And I say, well, you could teach a little bit less biochemistry or pharmacology. And they say, oh, no, we couldn't do that. So that's the story for the most part. Most universities have heard of me. They know that this is important. I don't think they fully appreciate the massive amount of alarming, actually, incidents of occupational chronic pain. Now, quite often, David, it's the student society that has invited me. So they contact me. They are active because they want to prevent problems. And at times I have been teaching online, or when I happen to be in a capital city to do some workshops, then I attend in person and they have me after hours. And then the faculty comes along and says, oh, this is good. And then we have the same conversation about not having enough time. So no, I don't have enough exposure, and I wish we could. You know very well, David, that when a top tennis player needs to change their forehand or backhand or serve, they often take off a year to get it absolutely spot on. Imagine if they learned it right in the first place. And that's what we should be doing dental school level.
It's because it's expensive for the profession. If there's an error in their education or a lack of education, then
Yes.
shortens the life expectancy or the professional life expectancy of a dentist. So therefore we have to educate more. Maybe it's the educators knowing that they're actually looking after their own jobs because dentists aren't lasting long enough, so they have to keep churning them out at this end instead of making them last longer at the other end. But that's the whole health conundrum, isn't it? Do we keep people alive, or do we let them get these illnesses? Do we not prevent these illnesses so that they become damaged goods? It's like oral cancer. By the time somebody is diagnosed with an oral cancer, it's almost a death sentence, because there's not enough oral screening tests out there to get them before they become visible. And so this is the same with posture issues as well. People are living with mild pain or pain in general and just toughing it out while it's still doing them damage. This is not good for anybody, let alone the patients. Imagine being treated by a dentist who's in pain, who doesn't feel physically comfortable because they're in agony trying to do things. It's not good. How can we change that?
Well, again, it takes a lot of education. So I'm often invited, or I submit to present at conferences, congresses, dental events, because it's about educating everyone. And of course, I need to be invited into a dental school, because if I could get the message across that you can't do just any old thing with your body in order to get your work done, it's not okay to twist and bend any old way. I think that's the absolute fundamental message when you're holding postures or repeatedly doing something. And then there would be something to build on, but it seems to be overlooked. Everything, it's almost like that we are a disembodied pair of hands and eyes and brain, and the rest is a black box. That's how I look at it. I certainly was one of those. I never ever thought about, well, maybe I'm in pain because I'm doing what I'm doing. I never connected what I do in dentistry to my pain, and none of my treating doctors and physical therapists ever did either.
Yeah.
They treated various segments, massaged the shoulder, the left shoulder. It was burning agony. And they never actually said, well, Anikó, if you have your left shoulder up in the air and elbow, of course you'll be in pain. Well, nobody did that until I started training in the Alexander work. And then I understood that I was doing things I was not designed to do. It's not rocket science. It's just so left field.
It's just, again, it's problem solving, isn't it, Anikó? Because we often in life, everybody, just as you said, they treat the symptoms, but they don't go back and work back what is the cause. And it might be 3 or 4 things. I do it in business. They say, I've got this problem. And I go, well, let's unpack where this went wrong. And it went wrong way back up here. Now you're saying the exact same thing physically. It's the bad posture, which leads to all these other things. And then finally, the part of the body that hurts may be as a result of other parts of the body being out of place as well. You raised a very important idea in my mind, because we haven't touched on this. There are things that dentists do use to help them see better, microscopes and loupes. How are they affecting posture? Do they actually help dentists sit more still in the correct position? Or are they, loupes being attached to the dentist's head, are they actually causing extra weight if they move forward, because now they've got this extra 2 or 3 pounds on their forehead? Is that causing more damage to the neck?
Very good question, David. So let's start with microscopes. If a microscope is set up correctly, and unfortunately some of the technicians who set up the viewer in such a way that the chin is up, which means that the weight of the head, which is at least 5 kilos, 4.5 to 5.4. I think that to be a dentist, you've got to be so brainy that it's probably over 6 kilos. But what happens is that when the chin is up, then the weight of the head is compressing the spine. So a number of endodontists needed to have spinal surgery for that reason. So I always talk about how that should be set up. So that's microscopes. When it's set up properly, absolutely, it helps because the dentist can sit upright and see into the patient's mouth. With loops, so the traditional loops, for the most part, were not well designed. You need adequate declination, which is about 45 degrees, and most of them didn't have it. But just as importantly, anyone who was using no loops or traditional loops cannot sit upright and hope to look into a patient's mouth that's down there, because this joint here, where the head sits on top of the spine, has only 10-degree freedom to look down. So what dentists tend to do is to sit upright, and then around 67, they do a bend. And these joints are not designed for that, definitely not for the period and repeatedly as we do. So that's one of the big reasons why almost everyone has neck and back issues. Now, the refractive loops that came along in the last maybe 8 years, something like that, they're like a mini microscope. They're designed to allow you to sit upright, look ahead and see down. The problem is that, well, there are a few problems. One, often dentists are not measured up well, and they're so into the habit of doing that, they're measured up in a slight sort of bent position or the head forward position. When they're well measured up and know how to sit well, and it's great both for dentists who are using a microscope or refractive loops to have a dental stool that has an upright back support. Almost every dental stool is backward leaning or it's got a backward curve, so that's another problem. What also happens is that dentists are so used to leaning forward and twisting and bending that they do it even with the refractive loops, which again is harmful to the spine. And I say to dentists who are using these refractive loops or ergo loops, as they're often referred to, is it's a mini microscope. Dentists use a microscope, don't bend the microscope, they move the patient. Dentists are not used to asking the patient to turn, chin up, chin down, and also move your stool. I say to dentists, don't twist your spine. So that's the story on loops. They need to be right. A lot of manufacturers are not designing them correctly. I call magnification loops and dental stools an inner and outer ergonomic interface. You need to know how to use it, and the product has to be right. And quite often, neither are right.
That's interesting. And because I was just going to ask you from what you just said, it's great information about loops, because as a young dentist, I thought, I'm going to survive without never needing loops or magnification. I'm young, I'm fit. And of course, it just happens. It's from habit. I guess I had short-sighted glasses when I was 15, and then I had a laser eye surgery, but eventually you lose your arms don't get long enough to be able to read well. And so that's one thing. But I was going to ask you about stools, because, I never used one, but that Bamback saddle stool, are they better than a traditional stool? Like you talked about having the backs upright in a traditional stool. Well, the Bamback saddle stool has no back. Are you a proponent for those, or is there a science to them, or are they just a trendy thing that somebody thought they'll throw at dentists and see if they could sell them to them?
Right. Well, Bamback did a brilliant marketing job. So the story on saddle stools is that a lot of dentists love them. For women, they are a little bit too wide. For most women, they push the thighs apart. From my knowledge of the biomechanical design, it is better for the ischial tuberosities or the seat bones of the pelvis to be on a flat surface rather than on a curved surface. However, if someone's happy with their saddle stool, that's fine. I'm not a fan of them. And I find that most dentists sit a fraction too high on them anyway, and that has an impact on lower back pain. But coming back to stool design, traditional stools are usually, the seats are too soft.
Mm-hmm.
The seat should be firm, ideally slightly forward sloping so that you can unload the weight of the legs. Each leg weighs at least 12 kilos, and you want to give that to the floor. Now, the backrest is only helpful if you're using a microscope or the ergo loops, or just when you're talking to the patient. Otherwise, when you're doing your work, If you are not using loops or using traditional loops, you need to pivot for your torso slightly forward at the hip joints and then look down those 10 degrees, provided you have sufficient declination angle on the loops. So you can't use the backrest. And I have yet to see a really well-designed stool. And I have to say, I was so unhappy with the stools that I was seeing when I started looking at them about 10 years ago, that in the end I designed a stool, or I gave suggestions to Australian Dental Engineering, and they created the Dr. D for dentist stool, which I didn't receive money and I'm not involved in the sale. I didn't want to be recommending something that I'm profiting from. I just wanted a stool that I recommend.
So there's a recommendation for dentists. And also in what you said, Anikó, in that you said that if they're using the saddle stool and they feel comfortable, that's okay. They still could be doing themselves some long-term damage, because you open my eyes up to the fact that the pelvic sit bones need to be on a flat plane. And of course, the saddle stools don't have that. So ultimately, if you do that for long enough, it's going to cause you some permanent damage, a postural damage. And as you also mentioned, the saddle stools tend to push the female pelvis apart.
The thighs apart.
Thighs apart, yeah. And that can't be good either.
No, it's not comfortable. And I always mention that I don't think they're designed for the female body. And at times, I don't think they're even well designed. But a lot of dentists love them. Dentists who used to slouch tend to sit a bit better on a saddle stool. And as long as they're comfortable, they need to learn how to sit. And I teach, how do you sit well? Because what people do whenever they see or they hear the name optimum dental posture, they go, oh, my posture, and I'll do an exaggerated. They do this pull up. Well, that's using movement muscles of the back to pull up, that's not sustainable. The movement muscles are not designed for lengthy contraction. So when I have enough time in a workshop or in a talk where I demonstrate, I teach people how to sit upright without pulling up and not collapsing. So there's an art and science to sitting up, utilizing your postural system and not your movement muscles.
Now, we've been very focused in this conversation about dentists, but you also mentioned to me before we started recording that you often go to offices, dental practices, and you talk to the dental assistant, the hygienist and the oral health therapist, and the dental office staff as well, about their posture and the ergonomics of their work situation and whether they could be optimally improved so that they don't go home with, sore necks from looking at computer screens in the wrong position, holding telephones under their ear and shoulder. That's not how it's meant to be designed either. Tell us about some of the things that dental practices can do in terms of getting you to come to their office so that everybody gets to work more comfortably.
Well, they need to contact me, and I usually have a phone conversation with the person who invites me, and I find out a little bit about the practice and give them an outline of how I can help them. And just to give you an idea, David, for example, in the sterilization room, usually it's the dental assistant who is picking up instruments that are contaminated and then scrubs and then moves it across. And I hope you can see me. So if I do this is repetitive strain injury. Something as simple, and I said to you, I think earlier, that this is not rocket science, it's left field. One of the things I teach them straight away is pick it up and then shuffle your feet across and then put it down. Do not do that. I usually have a twist and the rule. I do this. I say, that's what you're doing to your spine all the time. I teach them how to bend over the sink. I teach dental assistants how not to twist their bodies chair side. A lot of the time they need to stand up and stand in what I call a lunge, which allows them to look after their spine. I teach that to dentists when they stand up and do their extraction. On reception, for example, if the receptionist is handing over the FPOS machine like this, usually there's a higher counter. They usually have a sore shoulder. So I teach them to pick up the FPOS machine from underneath and then hand it over. And then this is not lifting. I teach dentists the same thing, that they pick up instruments and go into the mouth and already activating this. Go from underneath, don't activate. So there's a lot of very useful information that I not only teach by speaking, but actually demonstrate and then give them kinesthetic guidance. I usually take along assistant trainers who are very experienced in training a dental team with me. And we go through every aspect of the work, how they sit, how they reach across. And it makes a huge difference. And also something else, David, that's very helpful is that a team will be able to help each other in habit change. Because when we have been doing a particular, I call it not wrong posture, but harmful posture, it feels so comfy and familiar that we don't even notice we're doing it. So somebody else who works with you can point out, provided you give them permission to remind you, otherwise it's nagging. Every time that person in the team is doing the harmful thing, someone can point it out. And the more that pattern gets interrupted, the more likely it's going to be broken and then replaced with a better default. And it's an amazing team building experience to train together as a team.
I think you've raised an important aspect there, because a lot of things in the dental practice, even just on the business side of coaching, they work in silos. The reception works separately from the back office. The dentist works separately from the receptionist. They work separately from the sterilization, and they all need to know how each of them can help the others just by observing them doing incorrect posture. You raised an interesting point. One of the things that I teach people is what the first instrument they need in a dental practice is a chainsaw to get rid of that upstand at the front desk, because it separates conversation. Even you should be sitting on the same level. But the fact that you said that you're lifting the FPOS machine is bad, as a customer, I think the FPOS machine is designed very, very poorly, because the sensor is on the far side. You always have to, and if you're using your phone, you have to lean over and with your hands. And then if you're using your phone, you've got to press the button to make it work. In fact, I'm making a point now, and I love having the convenience of everything on my phone, but it's not helping my arthritis in my hands having to do that. I'm going back to holding the card, because at least with the card, I can reach that sensor and tap it and hold it, and it works. Whereas while the FPOS machines are designed with that sensor on the far side, it should be at the bottom of the keypad, not at the top and facing the shop assistant. So there's a crusade we could go on just to get ergonomically designed. How many things now are being re-ergonomically designed better than just even garden instruments are now coming with straps so that you can use them properly with the hand instead of holding them like pool cues instead of shopping baskets, shopping trolleys. There's a whole pile of things. There's lots of things, but I think the important thing, Anikó, is that we're looking at the dental profession, that it's not just turn up, drill holes, go home. One thing I wanted to ask about dental assistants, I found that for some reason, dental assistants are more prone to carpal tunnel injury by holding the suction in a certain way. Are you finding that as a postural cause, or is carpal tunnel more something that females get in their later midlife due to hormonal change?
I'm aware of a lot of young dental assistants and hygienists suffering carpal tunnel syndrome, and it can be multifactorial cause. What I do teach is, first of all, this is the carpal tunnel, and this is where all the tendons of the flexor muscles that contract the hand and fingers cross. Now, everything we do in dentistry and also away from dentistry, we are forever contracting, because that's what we do with our hand. So one of the very important messages I have and what I teach is that when you don't have to contract, don't. And what happens is that any time that we're not working, we might be doing this or that, and that's still a contraction and we're not even working. So the only rest for the hand is a extension. When I'm giving a talk, I always say, now look down at your hands, don't change anything, and what are you doing with your hand? And everybody's doing some version of this, and they're not doing dentistry or doing anything else other than listening. So I train people to do an extension, whether you can do it on your thigh or, if possible, on a table, and then give everything, the hand, the palm, every finger, forearm, good extension. I suggest to dentists, clinicians, that while they're waiting for their dental assistant to get something or mix a material or whatever, instead of just grasping the instruments and waiting, put the instruments down, and then with your gloved hands, do a really full extension, even for a few seconds, it breaks that contraction cycle. We need to look after our hands. It's our livelihood. Now, we can't walk around like this. However, you can put things down. We tend to carry a lot of things. And a really important one I want to just say to your listeners is that lately I've had a number of dentists who had to stop working because they had inflammation in this joint. And what's happening is scrolling and texting with the thumb. The thumb is not the same as the fingers. The thumb has got one left joint and is designed to do that. It's not designed to do this. So I say, the smart way to be on a smartphone is to message like this. And then they say, oh, Anikó, that is so old-fashioned. My mom does that, and it's very slow. And I say, well, do you want to be slow and old-fashioned at texting and have a long career or not?
Very, very, very important. Something I can't do with my thumbs is text with thumbs. I'm very much a finger texter as a result. A one-finger texter. This is a really important topic, Anikó, and I'm really glad that we've had this conversation because it's opened my eye at the end of my practicing career. But what I hope is that for anybody watching or listening to this podcast, that they reassess how they're practicing dentistry. And if they know somebody younger or they've got younger practitioners or younger employees in their practice, they need to educate them that, in the old days, and I said this, people when I graduated as a dentist, people used to come to the dentist at age 65, get a new set of dentures, and then they'd be dead by the time they needed their next set of dentures 7 years later. And now people are retiring, supposedly trying to retire in their late 50s, early 60s, and then they're living into their 80s and 90s. So there's all those extra years that they need to be healthy, and they can't wear themselves out at work because there's no fun being in pain when you're old. It's hard to get better then. And so they need to wind back the clock and say, how can we change things today? And if we can change things today, that's good. But better still, how can we help other people change things before the problem that we're seeing starts to happen? Because economically, for all professions, it's better to keep people healthy in their profession and so they can work rather than replace them as they get work-related injuries or lifestyle-related injuries from being in the wrong position through lack of education. So I take my hat off to you. I'm glad that we've spoken. If anybody wants to get in touch with you, Anikó, what's the best way for them to find you?
If they Google Optimum Dental Posture, they will find me, .com. They will find me and they can reach out to me. I'm happy to help. Sometimes dentists will register and do a program with me. I'm happy to help anyone, whether they ever do a program with me or not. I suffered for so long that I'm passionate about reducing the risk of occupational chronic pain in my profession. So I'm always willing to help out.
Well, thank you. And I'll steer them to you. I'll also put your LinkedIn profile on there as well so that they can contact you that way. Is there an email address that works well for you, or there's a box on your website to contact you?
Well, they can contact me that way, or dr.anikó.ball at optimumdentalposture.com.
Got you. Lovely. All right. Well, Anikó, thank you very much for your time today. This has been an eye-opener for me. I'm sure it's going to be an eye-opener for my viewers and listeners as well, and really appreciate your time. Thank you again for being a guest on the Ultimate Dental Podcast. Really appreciate it.
Well, thank you. It's been a pleasure talking with you, David.
Lovely. Thanks so much, Anikó. Thank you for all you're doing for the dental profession.
Thank you.
Thank you for tuning in to another inspiring episode of the Ultimate Dental Podcast. We appreciate each and every one of you for being part of our dental community and joining us each week on this incredible journey. If you found value in today's episode and you don't want to miss out on future episodes packed with expert insights and actionable strategies, here's how you can stay connected with us. Firstly, hit that subscribe button. Whether you're listening on your favourite podcast platform or watching on our website, subscribing ensures you'll never miss an episode. Secondly, share the love. If you know a fellow dentist or colleague who could benefit from the wisdom and knowledge that we share here, please share our podcast with them. Also, please share the podcast on your socials by simply clicking on the social icons wherever you view or listen to this podcast. Together, we can all do our bit to elevate the dental profession. And finally, stay engaged with us. We love hearing from you. Your questions, comments, and feedback fuel our mission to provide the best content for your professional growth, your personal growth, and for your practice growth. Remember, your journey to creating a dental practice and a business life that you love is our mission, and we're excited to be your trusted guide along the way. Thank you for being a part of the Ultimate Dental Podcast. Until next time, keep smiling, keep strong.